Okay, 2 o'clock on the nose. Thank you, everyone, for getting assembled so quickly. Welcome back. It's been a couple months. My name is Jamie Strauss-Clark. I am your facilitator. Nice to see everyone again. And I really enjoyed our meetings over the last couple of months. So thank you to everyone who was able to spend some time on the phone with Katie Rogers and me, giving us your insights. That was very helpful. I'm going to step away from that. I might be causing some feedback. That was very helpful, and hopefully you'll see your input reflected in today's agenda and process. Before we get started, I wanted to give our chair just a few moments to welcome you and thank you for your contributions and service. So I'll pause and ask our chair, Sue Birch, to give you a welcome.
Can you hear me? I think I'm on. So good afternoon, everybody. I want to thank all of you members of the work group for being here and really participating now in our second meeting. I also want to thank our audience members, members from the public that are here, because I really think it is important that clearly this is a priority, that we're making time traveling and focusing our energy and efforts on this very important work for the future. I also want to just point out a few very important things. There's core elements of this work that we really just cannot walk away from. The areas around coverage and access and eligibility, I sure hope over time that we really are going to have these elements woven into our reports and our choices. The issues around transparency and the true costs, and really around how these areas in service delivery, cost and quality, play out. Really important that we keep fleshing this out as we go forward. Innovations, what are some of the really extraordinary, promising practices and the innovations that are helping systems be more efficient and elegant and to really deliver. Certainly, everything around this work is a lofty goal, but with the right partners and our facilitators and our financial fiscal experts that are going to help us develop the final cost estimates, we will get there. And lastly, it's going to be really important for us, too, to be very thoughtful about the transition steps of just how would we deliver an estate on these particular models. So I want us to be always very thoughtful that while we have these core elements that have to be woven in, we also have to constantly be staying in a very high-level process, because if we get bogged down into too many details, we won't get anywhere. Our wheels will spin. So it's with that I know our facilitators and our expert consultants and our teams of supporters and the public process will keep giving us kind of the information to shape this work as we go forward. So I look forward to being with you all today, and it's with that I say, Jamie, it's back at you, and let's get going.
Okay, so I'm going to spend a little time, first of all, walking you through the agenda, then walking you through all the paper that you have in front of you, and then we'll do a few housekeeping items. So agenda today, our main focus is there's two pieces. One is to report back to you on the process that we've developed to get us from where we are today to our finish line on November 15th, 2020. And that is really reflective of the input that we received from all of you in those one-on-one meetings. So hopefully you'll see your input in that process, but we'll be walking you through that. Our other objective is to go into problem definition, to really define the problems with healthcare in Washington State as it stands today. And we're going to be working in small groups to do that. There's another piece of input that many of you provided in our conversations was it would be productive and helpful to work in smaller groups in the report back. So we're going to be doing some small group work today, and I wanted to share that because for members of our public, and hopefully you got the notification last week, for the middle part of our agenda today, from about 2:10 until I think it's about 3:50, is that right? We're going to be working in small groups. You're welcome to stay and listen in on those, or you can take the opportunity to enjoy the not rainy weather in the Capitol today. But you'll be able to come back and hear the report out afterward, and that'll give you an idea of everything that's happened in the groups. Note, though, that during that time, TVW will not be recording because there's 5 groups, and that just wouldn't be realistic. So that period of time will not be recorded on TVW. Let me just walk you through the agenda today. After we do our housekeeping and welcome piece that we're doing right now, there's going to be a 5-minute healthcare story. And this is something we're going to do at every meeting. It's going to be a different story each meeting of a Washingtonian who's experienced the healthcare in Washington. It's going to help us get an idea of the range of challenges that real people face with our healthcare system. That's going to happen at 1:10. 1:15, we're going to do kind of an icebreaker. Another contribution from our work group members was that it'd be really nice to have some time at every meeting to just build relationships and connect with each other, because the more we connect with each other, the more trust and real dialogue we can have. So we're going to spend a little time doing icebreakers. We're actually going to do those in the groups that are going to be our small breakout groups later, so you'll get to work with the same people throughout today. After that, we're going to, the moment you've all been waiting for, we're going to review the work group decision process. This is the process that was developed based on the input provided by all of you in these one-on-ones, and Katie Rogers is going to walk you through that. Next, we're going to go through the charter that we talked about last time and we took your input on and revised based on your input. So we're going to review that and hopefully affirm it, and that will be our guiding kind of constitution as we move forward. Then we're going to move into breakout groups, and there's going to be 3 in this room and then 2 in the insurance building next door. We'll have people guiding you over there. These are going to be facilitated work groups. There's going to be 7 people in each group. And we're going to spend the first exercise, which is about 40 minutes, well, some time for transition to get to your work groups. We're going to spend the first part of the exercise refining a problem statement. We've developed a straw man for you. Another piece of feedback we'd received from you was, give us something to react to. Don't have us work with a blank sheet of paper, because that's going to be challenging to get all of our work done when that happens. So we're going to provide you with a straw man, and as a work group, you're going to work together on refining that problem statement. Then we'll take a little break at 3 o'clock. Then we're going to come back and we're going to do a root cause analysis. And this is when we're actually do a deep dive into what are the causes of the problems with the healthcare system in Washington, doing that in small groups. Finally, after that, we're going to come back together in this room and do a report out. That's when our public and TVW can also hear the outcomes of these small group exercises. And then we'll close out, as we always do, with action items, next steps, and public comment. So before I move on, any questions about our agenda today? As a reminder, if you have questions or comments during our session, our process is that you will turn your table tent, or Dr. Kovar's here, turn your table tent on its side like that, and that'll signal to me that you want to make a comment. I'll do my best to catch when you turn it over so I can call it in order. All right, before we move on, I also want to do a quick summary of public comment from the last couple of months. It's going to be a really quick summary because we actually going to have printed versions, I believe, for our... I think I'm going to stand over here because every time I get close to that mic, I make some feedback. We have printed versions of the public comments for you to review, and I'm going to encourage you to review that because I can't do justice to some of the ways that people framed their comments. But just a quick summary, I had about 8 comments that were submitted. A few of them were in support of Senate Bill 5222. I'll just keep moving around so that I can not cause feedback. Okay, I apologize if I have my back to any of you. That's not intentional. So a few of these comments in support of a single payer system. We did have, and this is good for all of you to know for this meeting today, a number of comments reminding all of us, including me, to use our microphones at all times while we're on TVW. So please do, when we're speaking during this time that we're all together, remember to use your mic in front of you. And actually, let's pause for a second, have Pat give you a quick demo again about how we use our mics.
There's a button on the mic, and when your mic is red, you can speak into it. It's better to speak closer, more effective, and more efficient, and it can be heard. If you're going to move the mic, it's a great idea to turn it off first, because otherwise it sounds like this.
So I'll encourage each of you to read. There's not that many, so it should be a pretty quick read to read the comments. If we get a bigger volume, we'll figure out a way to get that information to you where you don't have to read through hundreds of comments verbatim. Lastly, I want to remind everyone of the public comment process, which is going to happen at the end of our meeting today. Sean, do you have the sign-in sheet? Okay, it's right here on the table. So if you would like to make a comment today, please do sign in. We're going to take it in the order that we have the list. We have, I believe, a 20-minute period for comments. So we're going to use a timer as we did last time for those of you who were here before. Each comment will have 2 minutes, and we'll, out of respect for everyone else who wants to make comments, we're going to stick pretty closely. We're going to stick exactly closely to that. So 2 minutes, so please plan your comment accordingly. Also, if you have a written notes or something to accompany your comment, it really helps us if you hand those notes to us. It helps us keep records. So please do share that with me when you make the comments. I'll review our process again when we get to the end of the meeting, but for those of you who are planning on making a comment today at the end, that's how we do it. Okay, I think we have time now to move on to our healthcare story, and Kelly Powers has offered to do our healthcare story today.
Thank you so much, Jamie. Before I get started, I wanted to wish the governor well on his hip surgery today, and I hope he doesn't have to suffer the slings and arrows of high deductibles, out-of-network providers and such. I hope it all goes really well for him and that he remembers that it doesn't always go well for the rest of us. I'm Kelly Powers, and I'm the exchange consumer on the work group, and my husband has his own contracting business. We have 2 daughters, one in college, the other in high school. I could regale you with personal stories about surprise billing, but I don't have the time. I could focus on narrow networks, but there isn't enough time. Instead, I want to talk to you about the new economic reality. There is an economic tsunami off the coast of Washington, and it is bearing down on my family. It is threatening our residents, your families, our state government, our local governments, and therefore Washington taxpayers. And that tsunami is the crushing cost of health care for Washingtonians. Did you know that 40% of adults in our country cannot afford an unexpected expense of over $400? This is according to the federal government report dated May 2019. That's $400 would just crater people. I want us to feel that number in our gut. I took a look around, and 40% of this work group would be this table to a couple of these people over here. When we, let's just imagine that 40% of us, that we have insurance, but we can't scrape together $400 for an unexpected medical expense, for example. Like, we don't have the cash, the savings, the credit card. We can't make it happen. And even if you take into account Medicaid, maybe we should be factoring in the $1,500 deductibles that are very common, or the $2,500 deductibles that are very common for many people. This doesn't even just affect people on the exchange. This is people with private insurance having this struggle. So I want to pivot from that reality of how many people in our country are facing this enormous economic challenge and tell you a little bit more about my family. So I just did our 2020 selection for our healthcare for next year, and it's going to be $2,300 per month, including the insurance for a college student. And that's over $27,000 this year on premiums alone. That's like buying a new car, but we don't even get to take it off the lot. It's more than double our 2011, which is a good marker because that's before the ACA. And we get a lot less coverage. All of the 2020 silver plans that came up for me had deductibles or had a copay of 30% for ambulatory procedures, ER visits, hospital stays, having a baby, what have you. 30%. That is really expensive. Like many in my age group, we're just trying to hold on till Medicare. But we've got 10 years to go. We can't handle the kind of increases we've endured over the last 8 years for the next 10 years. It would break us. I don't know what's going to happen. And then I'd like to share with you this story. It's an incidental story that I ran into a couple of weeks ago. I met a mom when I was volunteering at my daughter's high school. And when she learned that I'm working to get health care for all, her story poured out. She and her husband are naturalized citizens. English is their second language. They have 3 kids, about the age of mine, maybe a little younger. And she told me her husband took a job at Fred Meyer in South King County for under $12 an hour. She temps for the school district whenever there's available work. He now has health insurance, the dad, and the 3 kids were able to stay on Apple Health, but the mother of the 3 kids is not covered. They looked at the exchange, and despite the premium support, they realized while they might be able to scrape by and buy the insurance, they could not afford to use it. How, she asked me, can we spend money we need for our kids on insurance that we can't even use? And think back to that 40% that can't afford a $400 emergency. This family would instantly relate to that statistic. They would get that in the gut. And many Americans now, including me and my husband, we're beginning to ask ourselves, can we really afford this insurance? And as she's telling me this, I'm thinking of all my mom friends who have breast cancer. And so I ask a very direct question. But what if you were to get breast cancer or something serious? I'm thinking of her 3 children. I'm just, this is really unbelievable. And she answered me the most amazing statement. She said, I tell my family, if I get sick, just let me die. We must get a handle on affordability. We have done a valiant job of playing whack-a-mole, holding down premiums here by accepting rising copays or narrow networks over there. But what I'm here to tell you is that playing whack-a-mole is no longer working. A middle-class family of 4 with a mortgage can expect to pay over half their income on taxes and healthcare premiums. The remainder has to stretch to cover or forgo additional healthcare expenses that arise, groceries, clothing, utilities, childcare, retirement, college savings, transportation, possible home and auto insurance. Anyway, I thank you for listening to my thoughts today, and I'm thankful that we will be hearing from more Washingtonians with a wide variety of situations, I'm sure. And I truly hope we can come together and present the legislator with serious proposals that will address the cost of healthcare and the growing crisis of the underinsured. I know that if 40% of this work group were comprised of Washingtonians that I've been talking about, we would deliver that, and we would deliver it quickly. Thank you.
Thank you, Kelly. Appreciate you sharing that. I forgot to do a couple of things before we moved into the story, so let me just do some quick housekeeping. Reminder that restrooms, the women's restroom is out the door, make a right turn, and then a left. You'll see a sign there. Men's is the same, but just to the left, and then a right. I've been promised a new mic after the break, so hopefully I won't be taking your ears out anymore. There are snacks, and it looks like coffee here, so please help yourself, keep yourself nourished. On your name tags, you'll see colored stickers. That's actually how we're going to organize today in our groups. So when the time comes, and the time is about to come, I'll let you know when you're going to get up and get organized in your groups. We are going to do small group work, I think, moving forward in a lot of our meetings, and I'll make sure to mix them up so that you get to work with everybody. I'll make sure that you get mixed up into different groups every time so that you get to work with different members around the table. But today, we've done some work to put you in groups where there are people from different perspectives and backgrounds working together, and that was intentional. We're going to move now into, and I want to talk you through the paper in front of you. In front of you today, you have an agenda. You have the big 11 by 17 paper is the decision process. This is all in material that was emailed to you last week prior to our meeting. You have the revised charter, which we'll go through shortly, and you also have a draft outline. And the draft outline is very much a working draft. This is a draft outline for our final report. We gave that to you today as a tool for understanding the destination we're all working toward. So there's going to be opportunity at future meetings to get your input on that and refine it, but we wanted to get that out there so you had something really visual to lock onto as we're thinking about our process today. So, and those are all hole punch that can go in your notebooks. Please let me know if you missed the last meeting and don't have a notebook. We have extra ones for those of you who didn't get a notebook at the last meeting. We can catch up at the break. Okay, Dr. Weinberg, we'll grab one for Dr. Weinberg. Thanks, Tamara. Okay, we're going to move into our icebreaker now. So we have 5 groups. We have the colors yellow, red, blue, orange, and green. And I'm going to in a moment ask you to get up and organize. I'll tell you where to go sit. We're going to do something you might have done in groups before. It's called it's usually called 10 things in common, but given our time, I'm going to give you just 5 things. I'm going to ask you in your group to spend some time talking and come up with 5 things that you have in common. And no cheating. You can't say we all have a left ear. That's too easy. I want you to actually really dig in and think about 5 things in common. It could be anything. It could be your favorite Thanksgiving side dish. It can be something about your family. It can be your favorite vacation spot in Washington. So get creative. I'm going to give you about 7 minutes to come up with 5 things in common, and then we're going to share a few things with the larger group. So let's have everybody take a look at your nameplate and what color you're with, and then I'm going to ask folks who have yellow to get up and go organize over here. You can sit or stand. This is very informal. We'll have blue go over here. Let's do red over here. Green, and green can be on this corner, and then orange over here. So let's get up and assemble. And facilitators, if you want to join a group too, you're welcome to do that. Okay, we're going to have just another minute to talk, and then we'll come back to the group, and you can tell some of your things in common. All right, I'm going to invite everyone to come back to the table. Can everyone come back to the table, please? Don't worry, you'll get lots of time together today. Okay. So I'm going to ask a few of you to share some of the things in common that your group discovered. So over on the Senator Brown, what were some of the things that your group found in common that you can remember?
Sorry, we all live in Washington. No. We have a few others.
That's why you got finished so quickly.
No, we
Sounds
have a
like
few
there's
others.
some
No other.
secret things in common. Secretary Wiseman?
So we all have employer insurance.
Okay, that's a good one and related to our topic at hand. So well done. Okay, how about over here?
We all live in the Puget Sound region and recognize that our state parks and our outdoor access is a real gem of living in Washington State.
I live here. That's a good one. Okay, how about over here? Any things in common? Dr. Trick?
The Green Team, we realize we're all attractive, we volunteer our time, and we're all political junkies.
Ooh, everyone wants to be part of the Green Group, I think. Yeah. Let's see, who do we have over here? So Representative Macri was part of the attractive and political junkie crowd. So who have we missed? Who hasn't reported out? Okay.
We had the Orange Group. So we were very iconic with Washington, particularly the development of the Cosmic Crisp apple. We were all duly impressed by that. Chihuly glass and inspired by Mount Rainier. So we had a lot of commonality around those iconic Washington symbols.
A lot of good Washington love here. Did I miss any group? Who did I miss? Oh, yes, Kelly.
We would just add that we've all been to Minneapolis. Took us a while to get there. Yes. And we do not like to shovel snow.
I don't know many people who do, but that's a good one. Yes. Okay. Well done, everyone. That was. I was thinking about how even 5 things in common you could come up with that in such a short amount of time. So well done. I appreciate that. Let's dive into the work group decision process. And to cue that up, I just wanted to summarize some of the feedback that I had received from you in the one-on-ones and how that ties to our work group process. Hopefully all of you got to read the summary that was in the report that we submitted to the legislature, so you got a pretty good idea. And I will say I still had a few work group meetings after that summary was developed, but the feedback that I got in those follow-ups were fairly consistent, so there weren't any big changes from there. But some of the pieces that came up that I wanted to signal for you is, first of all, and this was a big takeaway, there was no single consensus. Trying to not do that to you. What's that? Maybe hold it lower. It's on. Okay. Thank you, everyone, for your patience. I'll have to confine myself over to this corner now. So some of the feedback that we received, first of all, there was no consensus on exactly the process that we should do here. There are people that have been working on healthcare reform for a long time, and there are a lot of good ideas for process and what success should look like, but no consensus on exactly how that's done. So to an extent, we needed to put a stake in the ground and say, here's the process that we're going to go with. But there was obviously a lot of consensus that healthcare, that there are a lot of problems with it in Washington state, that, like Kelly's story, affect individual families, affect small businesses, affect large businesses, affect providers, and a lot of the people that are around the table. So certainly consensus on that. I'm just going to grab, actually. Hold on. Wanted to make sure that I caught everything here instead of talking off the top of my head. So there was certainly consensus that it would be important to articulate a path forward. The question that I was asked by almost all of you was, how are we going to get from here to there? And so that's going to be the conversation we have today with regard to the decision process. I heard from a number of you also that it would be really important to do some problem definition. People around the table have a sense of the problems with the healthcare system from your perspective and your role, but it would be really helpful as a group to work out the specifics of the problem definition. So that's what we're going to do today. I also heard from a lot of you that coming up with some evaluation criteria or guiding principles by which we can evaluate some proposals for universal healthcare would be really helpful. And so you'll see that that factors into the process as well. A number of you had questions about whether we're talking about and we talked about this in our last meeting too, universal health care coverage or universal health care access. And so we're going to walk you through all of that in our process today, but that was certainly a question that came up from a number of you. Again, I would encourage you, if you haven't already, to read the report. It provides much more detail on what came out of those conversations. But hopefully when we walk you through the process today, you'll see your input and the input of your colleagues around the table reflected in that process. Last thing I'm going to say is that, as I mentioned before, there was no consensus on exactly how to do this. So we came up with what we believe best reflects your input and also how this has been done effectively elsewhere. We don't want to spend the next 11 months debating about process because, as Sue said in her opening remarks, we'll just spin our wheels and not get anywhere. So we're going to ask everyone, even if you look at this process today and you think, listen, if I was in charge of this group, I would do things differently. I understand that. That's absolutely fair. But we're going to ask everyone around the table to really get behind this and commit to this process that we're all agreeing to. We're not here to control the outcome. That's your job. What we're here to do is drive the process so we can get to November 2020 and have recommendations for the legislature. And with that, I'm going to ask Katie Rogers to come up and walk you through the process that we've come up with. You can hold this microphone, or you can use that one.
That's not going to work for you because it doesn't hook into the TVW. Do you want to sit down here and talk?
Sure. I have a friend coming too.
Okay.
Good afternoon, everyone. That was nice. So I'm going to go over this big document here. You all have it, and I think you received it in advance of the meeting. It's the decision process that Jamie just introduced. And what it does is it takes all of the future meetings we have coming up and defines what our objectives will be and how we're going to get there. Bless you. So I just want to walk through that with everyone. As you heard today, today's objective is to understand the problem and come up with some root cause analysis around it. So when you're working on that, keep in mind the scope of this work team as well, please. What's in scope, what other groups might be doing when you start thinking about your problems and root cause. So starting in February, we're going to do, I think this will be really fun and really interesting. This part is where we're going to develop the evaluation criteria. We're going to think about things like Sue mentioned earlier, access, transparency, eligibility, what the impact to the taxpayers would be, and come up with a set of criteria by which we will evaluate the options that this group creates. So it's going to be a map that we use to go forward. You'll also hear at the next meeting in February several different options for what universal health care can look like and has looked like in other places. And between the February and April meetings, we're going to send out a survey and have everybody on the work team rank which ones that they want to proceed with. And by April, we'll have it narrowed down to 3. So from April, June, and August, we will be taking those 3 models. We're going to, in April, there'll be an intensive presentation on all the 3 models that floated to the top so that everybody understands in full detail what it is that we're talking about, and we can tweak things around the edges as we go. But April, I have to wear my glasses now because I'm that age. April, June, and August, we will be evaluating, or you will be evaluating, the 3 models against the criteria that you all created. And what we are asking you to do is not evaluate one model at a time, but take each model and evaluate each of the 3 models against the criteria at the same time. So I think that will give everyone a comparative analysis as which will be more useful than just doing one model at a time and then having to come back and say, what were we thinking? What did we say about model 2? I'm seeing some looks around the room. The reason we're doing 3 models is because here's my friend, the actuary. That's what our actuary and their models can handle is 3 options. There can be 2 options that are very dissimilar, or 3 where we have 2 that are similar and 1 that's dissimilar, so that they can run all the data and come up with the costs and all of that. Does that make sense to everyone? Yeah? Okay. So as we do the comparative analysis with the 3 different models against the evaluation criteria, that will help refine what the group puts forward as a work product. And that will, actually become the work product once the actuary team has taken all of the information that we've come up with and run it through their models and come up with costs and other elements. Do you want to talk about that a little bit?
Sure. So my name is Jared Nason from Optimus. I don't have a tremendous amount of detail that I can convey to you folks today other than a high level. But essentially, as Katie mentioned, from looking at the 2 to 3 models in terms of coverage options, our intent is to take the information, stratify the different populations as we see it today in the marketplace, and look to where those models are going to place folks or how they're going to cover them. So we're going to do that by currently breaking apart all the different pieces. So employer, that's small and large group, the individual or the exchange marketplace, Medicare, uninsured, Medicaid, those on premium assistance, and break out the population. So that's kind of step 1, is to get the pieces, because we don't know where we're going to land. So what we can be doing right now is to spend our time making sure we have the pieces, we validated the pieces, and they make sense, so that along the way we can share some of this as we go, as we get to our cost estimates. The other component of this is going to be taking a look at the actual cost data for each of these populations. Now, we have to be mindful about what's covered and what's not covered. So we're going to go through a gathering stage to get that information over the next month and a half or so. But again, all this information is going to be pulled together, and we're going to evaluate, price out the linkages from where we are today to where we want to go, share the information with you, highlight the key components that are going to drive the costs in those areas, And then, there are going to be certain assumptions. I do need to be upfront here that we can't price every single employer package out there to match, one standard package. So there will be some assumptions, but we'll convey those as we get through the discussion and share that with the work group so that you understand. And we're trying to be as transparent as possible, but remember, we are all also working at kind of a high level.
Okay, thank you, Jared. And by September, we'll have come up with recommendations based on the outcome of all the evaluations. We'll be able to identify issues that we couldn't address as this part of this group and things that we think maybe the legislature would be advised to dig a little bit deeper in. And at the end of September, we'll be drafting a report, the final report that goes to the legislature, which is due November 15th, so that you all have it before our October meeting. So there shouldn't be any surprises in that report when you all receive it before our October meeting. The contents will be created by this group, and it will be a summary of everything that we've come up with, including the 3 models that we discussed. There may be one that comes forward as the best option that most people agree with, but based on our one-on-ones, we think the likelihood of that is probably not great. So that's why we wanted to do more than one model so everybody feels heard. Another important element of the final report, of course, is dissenting opinions. We're going to capture if there are strong positions that are outliers to the 2 or 3 models that we end up with, we want to capture that, do a good job of documenting where those are coming from, and make sure that those voices are heard in the final report as well. Yeah, questions?
Zach?
Yeah, I just have a clarification question. So, Jared, in your presentation, you indicated that you're going to be providing analysis on 3 models within the next month and a half. But Katie, you said September 2020 is when we would be seeing the 3 models and the analysis there.
Jared's going to gather data so that we can pull data like a data book so that we can develop them into cost models, right?
I'm sorry if I misspoke and that's what you heard. I apologize if I did say that. No, we're in the process of gathering. At this point in time, we will not have it done in a month and a half, although I'd like to think we could do it in a month and a half, but I'm not going to commit to that. So sorry about that.
I see some skeptical faces about that. Secretary Wesson.
How will the 3 models be identified, by whom, and then hopefully we'll have that information well enough in advance to be able to read them, understand them, and come well prepared?
Thank you for that clarifying question. The models will come from the February meeting where we plan to present a variety of models that have been developed in other states. Oregon did a model, I think Vermont did one, other countries, and then we can talk about refining them as we go. And then there will be that survey between February and April where the group will vote on the ranking of the ones that they think would best suit our needs with this work team, and we'll proceed with those top 3. But they can be refined here and there as we go as well.
Dr. Traco?
Understanding your methodology and knowing the RAND Oregon study, I think it would be important if we could to put the 4th model in there by default, which is the status quo.
I'm hearing a suggestion, if possible, that we have some kind of no-build alternative.
Okay, thank you. No more questions? Okay, thank you very much.
I'll just remind you, you have also the draft outline, which will give you an idea of the product that we're shooting for toward the end. So please do take a look at that if you haven't had a chance yet. And thank you. Dr. Weinberg?
I'm going to be sorry to miss the February meeting, but the reason I'm not going to be here may be of interest. I will be in Tonon-les-Bains, France. It's about 30 kilometers east of Geneva along the shores of Lake Geneva. And on the afternoon of February 7th, I plan to visit the hospital at Tonon-les-Bains, which I visited 12 years ago when I was there before. I would be delighted if anybody wants to come and ask me or email me or comment anything that you would like me to ask the folks at the hospital in Tonon-les-Bains about how the French healthcare system works from their perspective of people living in it.
Thank you for that offer, Dr. Weinberg. We'll miss you in February and hope you have a wonderful trip. Just actually a quick note on those lines. Dr. Weinberg and I are going to be getting together at the beginning of January before she leaves for her trip so that we can talk about any insights she might have to contribute on the evaluation criteria that we're going to be discussing in February. So I understand there might be a couple more of you who Randy and I talked about this already, who might have to miss the February meeting. Please do let me know if you'd like to touch bases beforehand, because I know that evaluation criteria piece is going to be really important to a number of you. All right, let's move on then. Oh, Aaron?
So I'm curious about what the consulting team is thinking about the components of the models that you're going to be presenting. I mean, healthcare systems are very complex. So, and even with all these bright minds around the table, I don't think we can digest an infinite number of variables. So I'm just wondering whether you thought about what aspects of health system models you're going to be parsing.
So to summarize the question, I think I'm understanding from Aaron asking kind of where is that sweet spot between enough information that we can really evaluate these models and too much information that might be overwhelming or we might not be able to collect data on. I don't know if we have the answer just yet.
Oh, it's on now. Are you asking, when we talk about a model, are you asking what, are we going to talk about eligibility, the benefit design, all of that? The answer is yes, and that will be part of what the evaluation criteria that the group develops. But we did talk about, and we weren't prepared to have a full discussion about it today, but we wanted to talk about using proxy models. For example, the current Medicaid model has a certain benefit design and eligibility and cost associated with it. The Public Employees Benefits Board is another model that's employer-based. The exchange and Cascade Care are further models that are public option, you know, that people are familiar with and could get their head around and tweak around the edges. But we would be going over in the full report out in April after the group has thought about it a little bit more and been surveyed. We will go through all of the elements of those different models. Is that what you're asking?
Well, yes and no. I mean, I'm thinking. To me, what we need to be looking at are the aspects of these models that differentiate them, right? So, I mean, in a sense, benefit packages, even eligibility, you can apply any definition of benefits or any array of benefits or any array of who's eligible to different structural and financing models. So I guess, to me, this group needs to be looking at the aspects of models that really differentiate one approach from another.
I understand what you're saying. And the examples I gave earlier were just examples. We need to talk about innovation. We need to talk about transparency. We need to talk about all the other elements, social determinants of health, those kinds of things as well. And one of the things that we're a little bit bound by given the time we have together and the resources, is the idea of creating something from whole cloth and being able to price it may not be possible.
So just to clarify that point, I want to make sure I understand. I think I do understand Aaron's question about how we're going to compare these, and particularly focusing on elements that differentiate each model from another. If I'm understanding your response, Katie, it sounds like we're saying we also have to be able to include elements that we can get data on for each of these models so we can actually compare them. Is that right?
Yeah, that's right.
Okay. So I think this is a work in progress, working out exactly what these look like, and it's also going to be dependent on which models we choose to evaluate.
Right.
Okay, but I hear what Aaron's caution is that we should particularly focus on those elements that differentiate the models from each other.
And that can be captured in the evaluation criteria as well. I mean, it's important to bring those elements forward because that's where we will be able to tell.
Any other comments or questions regarding Secretary Wiseman?
Apologize for asking a second question. On the models, I guess I'm trying to understand the path forward. And it gets to this question about universal health care and exactly what we're trying to do here. When we look at the models, are we saying, well, let's look at this model as if it applied to the entire population? Or are we looking at models to fill in sort of the percent right now who are uninsured? Or, so I'm trying to get a sense with these models, what it is we're doing with them.
Right. That's an excellent question. And that's one of the reasons we chose this, because when Jamie and I were doing the one-on-one interviews with everybody, there were so many different ideas about how to move forward. We had folks who want to do build on what we currently have. We have people on the work group who are interested in lowering costs and thinning, they say lengthen the line or thin the soup, sometimes thinning the soup. We have people on the work team who are interested in single payer. So within all of that disparity, we have to create something. That's where we're thinking the models would be. For example, one model might be universal payer, and the benefit design would look like X. Another model that we talk about might be expansion of Medicaid or Medicare for all or something like that. So we have sort of the overarching approaches and then the design of what is going to be offered within that.
Great, thanks. That's very helpful.
Okay.
We have time for one last question or comment from Zach, and then we're going to move on to charter.
So is one way to think about this that the group here will determine 3 models worthy of studying, and the consultants will price out those 3 models and understand how much it will cost the state and individuals depending on the 3 that the group come up with? Is that a way to think about what's occurring here?
It's a high-level way, yes. But to be clear, we want, it's going to be a balance because we want there to be this robust discussion about the components of the models as well. But yeah, that's a good high-level way to think about it.
I might add one more clarifying
Go,
point,
Jamie.
which is to what Zach just said. My understanding is the models that we'll be choosing from are ones that are based on existing models that have been applied elsewhere, not something that we cobble together. Is that accurate?
Yes.
Okay. Thank you, everyone. Let's move on to charter. In your pile in front of you, you should have a revised version of the charter. I sent you a clean and redline version of this so you could see where we made the edits. I want to just flag a couple of things for you on the first page, which is, if you look at the bullets under the charge of the work group, there were a few additions here that were based on the feedback that we received from you at the last meeting. So hopefully you had a chance to review this and confirm that the feedback that you provided was incorporated in here. The other part that I wanted to flag for you, trying really hard not to trigger that feedback, is if you go to page 3, under meeting guidelines, starting at the bottom, something that I heard from a number of you when I asked the question in our one-on-one meetings about other processes that you had engaged in and what had worked well in those processes. Many of you had talked about really clear meeting guidelines. And the original charter had some, but I decided to do a little building out of that based on the feedback that you provided me. So I do want to call that out because I think it's really important to how we all work together. My job is to ensure that you all have the opportunity to ask questions and provide comments. And of course, this is not changed about discussions allowing for development of consensus, but consensus is not required. Again, meetings will begin and end on time. That was there before. If you look at the third bullet under meeting guidelines, where it says at the meeting work groups members will, I want to flag a couple of additions here. So show up on time and come prepared to contribute to achieving meeting goals. That was there before. The new one starting on page 4, share the available speaking time. So respect the group's time and keep comments brief and to the point. Avoid repeating what others have already said. And when a topic has been closed out, avoid bringing it up again. We have, as you know, this 4 hours seems like a lot when we all come together, and then it goes by very quickly. So that's a really, I think, important way that we can all contribute to the meeting, but also make sure that we're hearing from our fellow work group members. Another one that I added is focus on successfully completing the agreed upon agenda and meeting objectives. If a member raises a problem, they will also try to provide a solution. I know that's not always possible, but I think that should be an aspiration for us. Stay mentally and physically present, listen attentively, avoid side discussions when others are speaking, and wait until breaks to attend to non-work group business. Fourth bullet is attack the problem, not the person. Work group members will respectfully challenge ideas and not the person. Voice concerns and complaints at the meeting, not outside. And then this one was there before, put cell phones on silent. So I wanted to flag those because those are additions and really reflecting the feedback that you provided in one-on-ones. Before we just do a hand vote to affirm our charter, any questions or final comments on what you see here? Okay. Start with Patrick.
Thank you. Is there a process where committee members can ask follow-up questions once a topic has been closed? Sometimes we have a chance to reflect on these things a little bit more after we've moved to another topic. What would be the appropriate way, or who would be the appropriate contact for us to make additional inquiries? And how would determination be made whether or not that information should be shared with other members of the group?
That's a very good question, Patrick. May I clarify, do you mean like if you're driving home at the end and you're thinking, oh, I wish I'd brought this up, or something comes to you a few days later, or do you mean in the meeting later on?
Any of those, actually. One of the topics we closed was the models. We'll look at existing models after that discussion was closed, thinking, well, does it have to be limited to that? But that's a conversation that should take place offline. I suspect others, I see some nods, may have similar kinds of questions on the drive home as well. So that was the reason for the question. What would be an appropriate way? Who would be the appropriate contact for us to ask those kinds of questions? And I hope someone would determine whether that was those questions might be worthy of sharing, and if not.
Got it. Okay, so if a discussion's been closed out, someone has a follow-up question either later in the meeting or sometime thereafter, what's the appropriate process for getting that to one of our project team members and then deciding if that gets elevated back up to the group design? I'm going to give you a preliminary answer because I'd like to noodle on this, but then I'll follow up with you or with the group. A preliminary answer, I think, is to refer that to me as your facilitator and main point of contact. And what I'll do is discuss it with you and then consider if it's something we need to put on the subsequent agenda or address as a group somehow. I will come back if that changes, but I think that's a preliminary process. Does everyone understand what I mean then? So if we've closed out a discussion, I've synthesized and said, here's the conclusion we've come to, and then something comes up for you later. For example, I suspect that some of you might have questions about the process or the model or have a further comment. Refer it to me via email. refer it to me via email or my phone. You have my contact information in your notebooks, and I will confirm with you how we will address that question or comment, whether we're going to bring it back to the larger group. Secretary Wiseman.
Two quick, I'm wondering, things that I do get to sort of, I think, the philosophy of what we're working on the third dot point under charge of the work group, under community-based health models. Can we say health and wellness? That really gets, I think, a broader thinking about what wellness is. And then on the fourth dot point, I know it says this isn't exclusive, but it feels to me like community-based organizations are key and are missing on that list of, if we're talking about how we manage care, et cetera, community-based organizations can be really critical in that.
Okay, so I want to clarify a couple of things. Secretary Wiseman wasn't able to join us at the last meeting, so this is his first time participating in the discussion of the charter. I don't necessarily want to reopen refining the charter again in any great length, but I think we should entertain the proposals from Secretary Wiseman since he wasn't with us last time. Are you able to hear me okay? I feel like there's a little, okay. So the suggestions are to, under the third bullet, change community-based health models to community-based health and wellness models, and then to add to the fourth bullet in that list of stakeholders that are including but not limited to, add community-based organizations. Do we have any concerns about those additions? Anyone want to challenge that proposal? Okay, so I'm going to confirm then that the charter that we're discussing affirming today will have community-based health and wellness models written into it, and we'll be adding community-based organizations to our list of stakeholders. Any other final questions before we affirm our charter? Thank you. Okay, so I'm going to ask everyone, and this is an important formality because this is, as I said, our Constitution. So I'm going to ask everyone at the work group to please affirm the charter by raising your hand and saying, I affirm this charter. So let's all do that. Okay, any nays on the charter? Okay. Aaron, are you being difficult? Oh, I know. Okay, we have an official charter with the two minor amendments that we just discussed, and I will make sure you get a final version for your notebooks. Thank you for that. We're actually a little ahead of time now, so we're going to break into our breakout groups, and I'm going to remind you what we're going to do. The purpose of the next couple of hours is to work together to define the problems with the healthcare system in Washington. And you're going to work in breakout groups of 7. The first half of our time together, you're going to be refining a problem statement, and we've provided you with a straw man. Now, I know that there's a lot of depth to the problems. It's not as simple as a high-level problem statement. So, we're already aware that the tendency might be when you see this problem statement to want to add a lot more to it. And we're going to encourage, our facilitators are going to encourage you not to do that, because the root cause analysis, the next step in our process, is when you're going to be able to do a real deep dive into the problems. The other thing I'm going to say is I know that and when we first thought about this exercise, we thought, well, we all kind of know the problems. We've all confronted them in our work. But in fact, what we're hoping for today is that some new things surface, because you're going to be sitting around a circle with people that come from different perspectives, different lived and work experiences. So we're actually really hoping that new things surface in these conversations. What we're going to do with all of the material that you produced today is we're going to synthesize that, and we're going to use that as one big problem statement and root cause analysis that we're going to use to inform our discussions in February about evaluation criteria. So the work you're doing today is really going to feed into the next steps. You'll see, just as an example around the room, you'll see these big printouts. This is our root cause analysis, and this gives you a visual idea of what we're going to come out with at the end of the day today. This is all going to get filled out. And when we all get back together later on before the public comment period, we're going to do a report out and actually hear what each work group comes up with. So I'm going to tell you how this is going to work momentarily, but I do want to introduce your facilitators today. We have 5 breakout groups, so 5 facilitators, 1 for each group. I'll be facilitating one. And then Katie Rogers and Liz Arjun are going to be facilitating. And then we have Rochelle, you want to And Gary from HCA are also going to be facilitating. We're going to have work groups, 3 work groups in here, and I'm going to warn the work groups in here, the acoustics in this room are tough. So we may have to move your chairs a little bit so that you don't have a lot of echoes and overlap with each other. 2 other work groups, you have a different challenge, which is you need to walk over to the insurance building, but we will lead you over there. Let me just grab my lists since I can't walk with this microphone so I can tell you where you're going to go. Just bear with me 1 second here. All right, so yellow, you're going to be over here with me. So if you have a yellow sticker on your tag, you're over here with me. Red is going to follow Katie to conference room 100V. Green is going to follow Liz to conference room 110. These are both in the insurance building. Orange is going to be with Gary over in that corner over there. And finally, blue is going to be with Rochelle in that corner over there. Members of the public, feel free to stay and listen in on any of the groups that you like. Or if you want to take a little break, we'll be reconvening here. It's on your agenda, the time that we'll be reconvening here to do the report out. So now I'm going to ask everyone to get up and come move over to your spots and we'll get started.